It is just a huge honor for me today to be podcast interviewing orthodontist Jan Kalika, DMD MS. He's a certified specialist in orthodontics and dentofacial. He is an active member of the American Dental Association, the California Dental Association, the American Association of Orthodontics, Pacific Coast Society, San Francisco Dental Society. He graduated with honors with Phi Beta Kappa from the University of California, Berkeley in '93, majoring in chemistry. While at Berkeley, he was in the Students Honor Society and Golden Key Honor Society. He received his dental degree from Harvard School of Dental Medicine. In addition, he completed a fellowship in Washington, D.C. in the field of dental health policy. While at Harvard, Dr. Kalika served as president of the American Student Dental Association, where he received a National Award of Excellence. He was a lecturer at the Harvard School of Dental Medicine and Harvard School of Public Health. He received honors in all clinical disciplines at Harvard School of Dental Medicine, the Soma Weiss Research Scholarship, and an international research fellowship from Harvard Medical School. Dr. Kalika completed his orthodontic training at University of California, San Francisco, where he received a specialty certificate in orthodontics and facial orthopedics and a master's degree in oral biology. He is the co-founder and on the board of several companies. DiagnoCat, an artificial intelligence company providing dentists with the cutting-edge technology to finish their cases faster and provide a proper diagnosis. Ozone, a disinfectant company with an FDA-approved product providing the highest level of sterilization, and Breathometer, a medical device company, Rhinogram, a telemedicine company providing virtual consultation and tracking of orthodontic treatment. My God, you are a brainiac. Do you do anything other than just read?
No, I have a lot of other hobbies for sure. Yeah. Spending time with kids is one of them.
Your own kids or your patient kids?
Well, both, but my own kids, are now, I have three boys, ages of 18, 12, and 10. So they need a lot of my presence.
Oh my gosh, I know. I have four boys. So I called you to come on the show. You didn't call me. I'm just extremely fascinated with everything you're doing, from AI to Therazone to DiagnoCat. Why don't we just start in order? I mean, you're my gosh, you're a co-founder and on the board of four companies. Let's just I want to hear what your brain, what your amazing mind is thinking about most. Let's start with DiagnoCat, an artificial intelligence company providing dentists with the cutting edge technology to finish their cases faster and provide a better diagnosis. Now, I remember when I got out of school in '87, the big thing was dolphin imaging, because that was the first time you could go in there and get a panoseph and have it traced on the spot. So, on the consultation, mom's like, hey, does my baby need ortho? But it was like another appointment. You had to do one appointment for records and then come back another appointment. And with Dolphin, it was the first time you could just tell them on the spot what's going on. So what are you doing with DiagnoCat?
So DiagnoCat is an artificial intelligence software that uses different neural networks to be able to come up with some of the diagnosis recommendations. And the first product on DiagnoCat we've done is a CT scan. So you take a CT scan, and what it does, it uses neural networks to create a panoramic transformation of a very, very high quality, and it creates every single section of the tooth. So we annotated more than 1.8 million teeth to be able to come up with the protocols and see if there's any tooth intrusion or not. And so the DiagnoCat basically is kind of a brain behind analytics, and it analyzes the X-ray much better than the dentist. So we've done the CT scans, then we moved to panoramic X-rays, then we finished the full mouth X-rays and periapical. Now we're finishing up the photos, and the next is the intraoral scans. So we will be able to analyze, everything, kind of a digital patient, take all of the records, and it will provide the information to the dentist and some of the things that we miss on every single case. And I thought that I don't miss things, but when I check myself and put things in DiagnoCat, I find out that I miss things that I would never otherwise, think that I missed.
Wow. And when you do the price of orthodontics. I imagine if you said, hey, braces is $7,500 and it takes 2 years. But if someone came along and said, well, I can do it in 1 year, I think that would be worth more money. I mean, if you went out in San Francisco and said, I can do all your orthodontic treatment in 1 day, God, it'd probably be worth 20 grand. So do you think, so there's a value for faster, do you think orthodontics is a lot faster today than it was 10 years ago, the treatment time period?
I think the orthodontics is definitely faster, mostly because of an ability for us to figure out, how to put teeth in the final position. I think aligners, and I was at the kind of beginning of the Invisalign when there were only a few orthodontists in the startup company. We were trying to figure out how do we get from point A to point B in the fastest way. And the fact that I'm playing chess, it really resonates with me because my game as an orthodontist is to try to figure out how to create the best position of the teeth in the shortest amount of moves, right? And so the good chess players, the excellent ones, they can count maybe 25 to 30 moves ahead. And the ones who are not so good maybe can do 1 or 2 moves ahead. So I think to be a good orthodontist, you could envision the case at the end, and then you need to kind of figure out what's the best way from the beginning to get to the end. So with the vibrational devices, with the diagnosis, with the new wire technology, we're definitely finishing the cases much shorter because we can do all of 3-dimensional movements right from the beginning. In the past, orthodontists would put the braces on, and first they would level and align vertically, and that would take 6 months. And then after level and alignment, they work on the rotations. And then after rotations, they'll work on something else and wear rubber bands. Right now, you can initiate all of those movements right from the beginning. So inherently, your cases should finish faster.
Now you're in San Francisco, right?
Yes.
Yeah, and everybody wants me to ask. Everybody comes on. The number one question is, would you? You got so many doctorates and master's degrees. Would you take the vaccine today?
I think I would take the vaccine today. Yes, I believe that the whatever negative consequences of the vaccine that we might see or not might not be as bad as if you get the COVID. So the question is, what's better of, 2 things. And vaccines, obviously, they've been accelerated through the Pfizer and other companies through FDA. They really pushed the foot on the gas pedal. And I think they got something out. We don't know what long-term consequences are going to be. But on the other hand, there's a lot of questions of the COVID, virus, of how much of the man-made things was, inserted in that thing, and I think we wouldn't know for a long time. I think it's kind of a better alternative than going through the virus itself.
Yeah, and would you have any preference over the Pfizer or Moderna vaccine? Or do you think that since they're both messenger RNA vaccines, they're the same, or would you have a preference for Pfizer or Moderna?
I mean, just my bias. I used to work at Genentech between my Berkeley and Harvard Dental School. I took a leap year and worked for Genentech. So I think Pfizer, I'm a little bit more of a believer in Pfizer. In terms of effectiveness, I think they're very close to 93, 94%. If I had a choice, and it's just anecdotal, there's no science behind it, I would probably go with Pfizer.
Huh. Now you're born in Moldova.
That's right.
So that's kind of close to Russia. Would you take the Sputnik vaccine?
No, I would not take the Sputnik vaccine.
But they were the first in outer space.
That's right.
Now, is the Sputnik?
I would go to space on the Sputnik, but not take the Russian vaccine.
Was Sputnik a attenuated vaccine, or was that also a messenger RNA vaccine?
I believe it's an messenger RNA vaccine, and the people behind the vaccine are very, very smart people. I just don't know. I don't trust a lot of science, that I don't have strong evidence on. And to be in all fairness, I haven't really looked into the Russian vaccine, so it could be a better option. But number one, I'm not from Russia, right? Number two, I know that things don't go through as stringent regulatory requirements in Russia as they do here with FDA. So my trust level is just not the same. And, I know that the people behind the vaccine in Russia are brilliant people and amazing minds. So they could be better than what we have. But I don't have the evidence and I don't have the faith as I do in the FDA process.
Yeah, I mean Russia. I mean, my God, they were the first to land something on the moon, in space, first woman, first dog. I mean, they're crazy. If you're in Silicon Valley in the United States, what is considered the Silicon Valley of that area? Romania, Moldova, Ukraine, Hungary, Poland. Is it Belarus? Is Belarus the high tech capital of Eastern Europe?
Belarus has a lot of high tech people. I think there's a whole area of Silicon Valley kind of like outside of Moscow. And then there's a very strong computer, center outside of Cluj in Romania. So I think they're kind of similar in terms of the size and how much outsourcing work is being done. But Belarus has a big technology hub, and so is Romania, and the same thing is outside of Moscow. That's because the technical background and the education in physics and mathematics and computer science was very strong.
Yeah. But my favorite country in that region has got to be Budapest, Hungary, for the Michael Jackson concert in 1996. That was the best concert the world has ever seen. There will never be another one that good. One of the problems when you start talking about the cloud is, you're not a dentist uploading a PA or a bite wing. I mean, you're uploading these big files, and a lot of people who want to do dentistry on the cloud, they say everything's perfect until you get to these big CAT scan files, these big CBCTs. Is that still an issue, or have you guys found a way to get a CBCT on the cloud that doesn't take an hour to?
We absolutely have found an ability to store CBCT in a cloud. And when I take CBCT, I put, when it goes through the Diagnicat software, I can share it with the dentist and they can just click on it and open it up. And it has all of the slices and everything on the CBCT that I need. So, the cloud technology is definitely there. And, the sharing is available and the storage is very secure. So we're doing it with a very high speeds and very secure environment.
So you would say, but it seems like, well, here's what I don't understand. I come from the restaurant business, Sonic Drive-In. My dad had 9 Sonic Drive-Ins. And I just can't believe that companies like McDonald's with 38,000 locations, that every single location they got a computer and a server and all that stuff. You would think people like McDonald's and Burger King, that they would all just have dummy terminals on the cloud. Why do you think that it's not like that yet? What is the holdup on the cloud? I mean, like dental offices, like I don't want to have the server and all that. I'd rather just have a bunch of dummy terminals and have all that stuff somewhere else. How far away are we from that?
We're very close. I think, all of my environment is in the cloud. So I believe that, there's new softwares that are coming in. CareStream has a software called Sensei that's a cloud and it combines all of the disciplines. I know that, Henry Schein has that Dentrix Ascend that's in the cloud. Most of the QuickBooks that we manage financial part is in the cloud. So I think we are, we are in a cloud environment already for those who want to go.
Okay, so next is an old deja vu for me. You have a company, Therazone, and THER, Ozone, and it says on says the world's most powerful natural ozone disinfectant kills 99.99% of common surface pathogens, including bacteria and viruses. When I got out of school, there was a new thing out. It was called a halimeter, and it would measure aromatic sulfur compounds. So someone would come in and they'd have bad breath, and you would measure it. And I did a bunch of experience with my kids on that. Before they go to bed, I'd have them brush, floss, use mouthwash, everything. And they'd wake up in the morning and they'd only blow like a 30 or 40 or 50. And then the next night, I'd have them each eat like 3 Oreos and milk and not brush, not floss, none of that stuff. And they'd wake up the next morning and they'd be blowing like a 400. And now I see ozone's kind of coming back. And you see it in some of the mouthwashes, chlorine based instead of alcohol based. But what does ozone in dentistry look like today, and how's Therozone going?
Well, Therazone is still, we got FDA approval and we have a unit that disinfects the water, mostly the water lines. But we've done a lot of microbiologic studies on the surface, and we find out that actually, when you wipe the surface of the table or surface of the dental chair or the computer screen, it kills most of the pathogens. So, there's some of the dentists use the ozone in applications such as disinfecting the canal. Those are not the recommendations that we provide because they're not FDA approved. So right now we're only FDA approved for water sterilization and water lines, and there've been some, bad cases of bacteria, for the water that's sitting in the dental line that all of a sudden gets into the bloodstream. So there's a lot of, I think the ozone is a future of disinfection because it kind of turns into, oxygen and water eventually. It breaks down. It's very safe and it's very natural. There's no chemicals that are involved.
So you think it's so you're waiting right now for FDA approval?
No, we have FDA approval for the water sterilization.
And has COVID, this pandemic, changed supply and demand? I mean, has it changed your business model?
No, we're still we haven't really started selling the product. We're in the manufacturing stage where we manufacture the ozone. It looks like a coffee machine. You put a charge through it and the water gets sterilized. So, and we're still in the manufacturing stage. So, we don't have any effect from COVID.
So COVID's not going to be a deal. Now, your other is Therozone, and your other company, Breathometer. Is that kind of the same company?
Yeah, Breathometer is not my company. I'm on the board of Breathometer, and it's a company that uses sensors and measures sulfur in the breath. So it's a totally different company, and it's a very interesting situation because it measures gram-negative bacteria, which we now find in different diseases like Alzheimer's disease, and they've done autopsies of the brains, and it's the whole connection between the dental health and the overall health. So Breathometer is a little tiny device that's integrated with a phone that uses sensors to measure the sulfur level, and it obviously shows somebody where their gram-negative bacteria is at a high level.
Are you pretty excited about that? I mean, how's that all going?
It's going pretty well. The company is now getting some, testing and sensors, and we already have a prototype. We use the device. Some of the consumers used it, so it's going to be the future. We'll be able to figure out the risk profile of a patient by using a breathometer because it's really an indicator of periodontal health. Most of the destructive bacteria in periodontitis are gram-negative bacteria. And so when you measure the gram-negative bacteria, you'll use questionnaires, you'll use artificial intelligence, you'll know exactly where the health score and the health risk of a patient is as it relates to oral health.
Now, will we get a refund if the artificial intelligence machine takes over the dental office and makes us a slave?
Yeah, that's gonna take. I mean, I think it's gonna be a very helpful tool, but I don't think the refunds are in order, at least for the near future, because there's more resources spent on development. But maybe one day, yes. I mean, there was nobody before who beat the world chess master, and then the MIT came up with a computer, and then finally the computer became smarter than the chess master.
Are the computers smarter than the chess masters now? Is it game over for humans?
Absolutely. Yeah.
Yeah. Huh. So, I've been, I'm a little, I'm 58, so a lot of these things we've been hearing about for a long time, and I always tell the young kids things take a lot longer than you think. So AI, is it bleeding edge, leading edge? Where is it really? Because I've been hearing about AI. I mean, I think the term was coined in the 1950s. So it's probably been around 70 years. But is it about to reach a tipping point, do you think?
I think it's about to launch. There's multiple companies going through FDA approval. We are one of them. And I think that the technology and the cloud computing and an ability to use neural networks just came in light very recently. So I think we haven't seen AI. And what we see ourselves is the things that we're able to see about the joint, about the teeth, the sections, we've never been able to do before. So we automatically trace the 3D cephalometrics in 3 dimensions. We automatically detect if there's crowding or spacing. We can see a 3D image of TMJ in 3 dimensions. We could see the condyle in the joint. Those are the things that we've never been able to see before. We can come up with diagnosis and treatment and how effective the treatment is on the pediatric patient. And this is all done by AI. So I think it's going to change the world to the better. And I think it's the future, absolutely. I'm 100% sure that in 20 years, most of the dentists are going to use some sort of AI. And they're going to use mostly AI in digital patient diagnosis, digital smile design, and also AI in determining the health of the patient. We are working on an ability to create a health score for the patient based on the digital records. So we will know how healthy the patient is. And this is something that was never done before. I think that the opportunities and the potential is unlimited.
So, Jan, you're an orthodontist. You got several degrees. You're on top of so many different things. What are you most passionate about today in orthodontics?
I think my passion today in orthodontics is an ability to help patients, especially with the sleep apnea consideration. I think there's a big hidden epidemic that's going on that I think we'll live through, and now we're finding out more and more things and I know, because I have a sleep apnea myself. When I was a kid, I had sleep apnea. I think the pediatric sleep apnea is a very exciting new area that orthodontics can contribute so much. And I've had privilege to have very good teachers from Europe when I was going in UCSF who really thought about sleep apnea early. It's becoming more popular, and I feel like it's our obligation as orthodontists to be able to treat sleep apnea patients, to be able to improve their airways, because the epidemic comes because of several things. Number one, the diets, the new kind of more Western diets are not allowing us to have all the teeth that fit in the mouth, and there's a lot of crowding. The second thing is that insurance companies are not really covering the removal of tonsils and adenoids because they need really strong indications. And before, most of the kids got tonsils, adenoids out to help the airways. So now you have this small constricted jaws, you have adenoids and tonsils, and you're just constricting your airways. And a lot of kids are snoring at night, and they have sleep apnea that hasn't been discovered. And a lot of kids are getting Ritalin for attention deficit disorder, where orthodontists can really help those patients, get sleep apnea out of the way, especially on the pediatric side. Adult side is also very important, but I feel like because we're specialists in growth and development, and we understand how to develop the jaws and how the jaws are going to grow and predict it, and we'll be able to see things in 3D like we're seeing it now with artificial intelligence, we'll be able to help so many children. So I'm very passionate about that aspect of orthodontics.
Wow, it's so true. After I took my first 2-day weekend course on sleep, I was surprised at how many times I'd be over somebody's house and like the 5-year-old's taking a nap on the couch and he's just over there and you can just see. I mean, he's grinding his teeth. It sounds like marbles, or he's breathing issues, and it's funny how I got out of dental school. I'd never heard any word about sleep, and now it's all you hear about. Some dentists say though it's fad because they came out of school, they never heard it. Now everybody's talking about. What would you say to a dentist who's thinking sleep's a lot of hype and fad? What would you say to that?
Well, I would say that, I can just express my opinion with some of the studies that I've read and a lot of anecdotal evidence, but a lot of conversations with parents and moms and pediatricians and, pediatric ENTs, that I think there's definitely a merit to the sleep apnea. I mean, listen, even people who are very successful, like Bezos, says his secret, in business is that he gets 8 hours of good sleep, right? And I feel like, there's so much that's happening in the sleep. We know that most of the people grow the most in their sleep. Why is that? Because there's a lot of growth hormone that's being produced. Why do people have more sleep apnea in their sleep? Because they're laying down and their tongue falls back, right? So there's a lot of things that happens in the sleep that we haven't studied as much. The interesting thing is I'm one of the partners in a company called Mon Baby. And my Mon Baby is also kind of a high-tech company. It uses a little baby monitor, which it looks like a button that attaches to the pajamas. And if the baby turns to the stomach, it starts ringing parents' cell phone. And we created a full monitor, but we also had a stethoscope that we could put to the baby's, throat and from outside, obviously, and we could hear a lot of noises that are happening during sleep. And sudden infant death syndrome, we still don't know why it happens, but we do know that when they do autopsies of those kids who pass away from sudden infant death syndrome, a lot of them have hypoxia episodes with a lack of oxygen. So it's undisputed that there's a connection between the sleep and the oxygen and how much oxygen is coming in. I mean, there's been studies over studies. So the dentists who are refuting that fact, I think that they can just learn a little bit more and brush up on things. But I think this is a new area that orthodontists will be able to help tremendously. And I think patients and moms and dads as well, but are looking for the solutions for their kids and why they don't have attention in school, and why they have certain many problems, why they're snoring, why they have bedwetting, and I think part of it is the oxygen level in sleep.
What do you think about the status of ortho? I mean, there's 12 specialties, and it seems like the most disruptive forces are in your specialty. I mean, from Smiles Direct Club to Candid to all these different technologies. In economics, people think that competition is really good for an industry. Do you think this direct to consumer and all this technology is going to be good for orthodontics in the end run, or do you think it's a little too disruptive?
Well, I feel it's very disruptive. On one way is that all those companies are expanding the market, right? And so they're going to consumers who otherwise wouldn't consider orthodontics or wouldn't be able to afford orthodontics. Now, I do believe that they can only handle very simple cases. Even with the use of an AI, and maybe after many years, those systems can be more sophisticated, but you need to see the person. There's a lot of information that comes from the history, medical history, chief complaint. It's a very dynamic system where you have a TMJ, which is like a double joint. You have, 32 teeth, if they have wisdom teeth, you have interaction between each other in three-dimensional space, and sending impression to direct-to-consumer company is okay to do very simple cases that are relapse, but some of the more complicated cases have to be treated by the doctors because the patient can bite in the wrong place and then they can produce different results. And so all this, I feel like, is not going to really affect orthodontists as much as we think that it will affect us. It will put some time, money pressure and some maybe time pressure in terms of us finishing cases sooner, which I think orthodontists need anyway. I mean, we need to be able to have efficient treatments. I hate to see cases that roll into my practice who've been in treatment for 5-7 years, or some cases that need to be treated in braces that got Invisalign, and now they're not fitting well because there's some merits for both systems, but some people go overboard and they use too much of one, and then they just don't look at the actual case to be able to come up with a treatment.
On our show, at least a quarter of the listeners are still in dental kindergarten school. They haven't even got out of school yet. They're very young. And then they come out of school and they go get a job, and mom looks at them and says, you're referring me to an orthodontist. That's a lot of money. That's $6,000-7,000. Is that just cosmetic or is that health? And how would you answer? I mean, you got a degree in biology, chemistry, dental medicine. How much of Invisalign and all this stuff is to make you pretty as a peacock so you can attract another primate and reproduce and have offspring? And how much is just health?
Yeah, I mean, I hope it's both. But, I haven't been successful of chances of the mating stuff, but I think that it's mostly health related. I mean, our first responsibility is health, right? If we can, I usually tell, when I explain to patients in simple ways, I said, listen, if you don't have bad bacteria in your mouth and you brush and floss and you don't have genetic predisposition and you have a good structure, engineering of your teeth, you should be able to keep your teeth for the rest of your life, right? And so a lot of orthodontics is the second part. You need to have engineering of the system where you have the most, your lower jaw probably moves more than any other part of the body. Your muscles are moving. It's very complex. If you can get the engineering and the architectural part, right, and you can get the teeth and the bite where they're in a proper occlusion and, deal with bacteria and now viruses, obviously, then you should be able to have, a good overall dental health, which is now, we know, directly connected to overall health. And I think we'll find out there's more and more of this connection. And the fact that Harvard is now doing dental physicians again, and the dentists are going to get MD degree, I think that's going in the route of, we're going back in full circles. We used to be, finishing medical school and specializing in dentistry, and then we're separated as dentists, and eventually we're going to have to be dental physicians.
So when did Harvard switch the degree from a dental degree to a dental medicine degree?
No, I don't think they switched, but when I was at Harvard Dental School, first 2 years was spent in medical school. And then we took some dental classes. And I think now they're offering people to get double degree, MD, DMD. I think it's 5 years versus 4 years. And they're going to come up with a degree of dental physician. There will be, general physicians with an MD, and they also will have DMD. So I think Harvard is kind of, to my knowledge, is the first school that's really taking the undergraduate or the dental students into the medical arena.
When you look at, I've read a study before that said, take military, take a U.S. submarine. When it goes down, it's not going to come up for half a year. And they have had this triage deal where you sit down and it knows your age and your everything about you, and you put in your symptoms. And they claim that is like 95% accurate. But if you just walked into the average emergency room, your diagnosis might not even be 80% accurate. When you're back to DiagnoCat, when you're looking at all these algorithms in this big database, do you think doctors think they're better at diagnosing and treatment planning than they are? I mean, there's some psychological effects. What is or do you think are you seeing that they're pretty good we made it a little better, or are you making it a lot better?
I think we're going to make it a lot better, especially in the areas where we're going to see three-dimensional structures. Because the doctors, the dentists, most of them don't really know how to read CT scans. Once you get into 3 dimensions and you see the condyle of the joint, you see how the condyle is flattened, which is very difficult to see, and we can reconstruct. We have automatic segmentation of teeth. So when you take CT scan, I press the button, and I'm going to have all of the teeth and the roots in 3 dimensions, how they're sitting in the jaws. And I could have a TMJ. So this segmentation, automatic segmentation, I think we're probably the first ones or maybe the most advanced in the market to discover it. But, that gives so much more information to dentists and orthodontists. So now we don't even understand how much bone that's covering the teeth under the gums in 3 dimensions, right? All of a sudden, you're going to see a 3-dimensional picture and see, okay, I can't push this tooth forward. There's no bone there. Whereas orthodontists, made those pushing forward decisions all the time. And now a lot of dentists are, using Invisalign without understanding a 3D bone structure. They're pushing teeth out of the bone. And I see it all the time. And I think with DiagnoCat, the interesting part is we're trying to be an assisted diagnosis company and a managerial tool, and assist the dentist in diagnosing. So the dentist is an ultimate diagnostician. But on the other hand, everybody who says, no, I can diagnose better, I don't need DiagnoCat, will load 5 of their cases in DiagnoCat, and I get not a single one, not a single dentist has not missed 1 or 2 things, which is kind of interesting because if you could find things at the early stage, you can do a better prevention.
But yeah, doctors, they don't seem to be the humble type people. And, the Dunning-Kruger effect is it's a cognitive bias in which people with low ability at a task overestimate their ability. It is related to the cognitive bias of illusory superiority and comes from people's inability to recognize their lack of ability. Without the self-awareness of metacognition, people cannot objectively evaluate their level of content. What I think is really weird about it is when David Dunning and Justin Kruger work on that, he says, okay, his research would look at me and say, okay, Howard's a dentist. So since he knows so much about dentistry, he knows that he doesn't know everything about dentistry and works with all these specialists. So I would be more likely to be humble in dentistry, but say it was something, race car driving or whatever, I'd be more likely to overestimate my ability. So do you think doctors on the Dunning-Kruger effect, when AI shows them how much they didn't know, are they coming from the place of like, oh, that's cool, I missed 5 things, that's cool? Or do you see this, they're getting stressed out and thinking it's stressful for them?
Well, I don't think it's stressful for them. I think most of them feel like, some of them have this wow effect. Wow, that's cool. I'll be able to diagnose better and help my patients better. But a lot of them are saying like, I don't need it. Listen, I can diagnose good enough. My patients trust me, and I don't really need this AI thing. I can figure it out. If I don't see this now, I'll see it a couple of months from now, but I won't miss it, over like every 6 months periodic reviews. And so, yeah, I agree. It depends on the personality of a dentist, but some of them, who are technology savvy and really want to improve the care, they feel like, here it is. I really want this. This is going to be part of the future. I'm going to incorporate it in my workflow. Where others feel like, listen, if I don't have to spend money on it, I'm not going to incorporate it because it doesn't create revenue. They approach it as a business thing.
Back to the space about ortho. Is it just beauty or is it health? I'm finding out a lot of the things I learned, in the 80s aren't true anymore, but we used to be taught a thing called the BMW, like the car, the biological minimum width, and they would show that if you didn't have 1.5 millimeters below your bone and your 4 incisors, you weren't going to have blood flow, circulation. I'm trying to give wording to the kids because the mom wants to know, is this just for beauty or is this for health? Is the BMW, is that still a thing? Do you still believe that? It seems like most of the crowding is the lower anterior, and the lower anterior, it seems like, in fact, I personally think retention of ortho is harder than ortho. I think it's a lot easier to straighten teeth than it is to retain them. Do you think those lower anterior crowding, do you think that's a health issue and increases the chance that those teeth will be lost to periodontal disease when they're old?
Yeah, absolutely. I think it's a combination of the health and beauty, right? And I think health is number one, and the fact that lower incisors are super crowded and you're not able to keep them clean and floss because some of the surfaces are hidden, that's definitely a health thing. And most of the calculus, when the hygienists are cleaning, it's around lower incisors most of the time. And I think that that's a health thing, but also the beauty and being able to have a nice smile and keep the patient younger and have this confidence about themselves. And for people to see that their smile actually gives them so much confidence, but also an ability to stay younger and feel younger. I think there's definitely a beauty effect that orthodontists provide. I mean, I have to look at each case as the health and beauty, because I look at the smile line and evaluate. By the way, the artificial intelligence, when we take the extraoral intraoral pictures, it evaluates the whole face, like what's the proportions of the lower face height compared to upper face height, what's the aesthetic line, how far the chin is back. And so we get a full prospectus of knowledge. And so it's absolutely beauty, but it's number one health.
I want to, again, it's Dentistry Uncensored. I don't want to talk about what everybody agrees on, and I want to go right to my homie's juggler vein. A lot of the controversies, at least 1 in 5 dentists believe that there's never an indication to pull the first 4 bicuspids, and that the orthodontists who do it are butchers and they're destroying the face and blah, blah, blah. Yet I've seen cases where, my God, there's no way you could do this ortho case and keep these teeth over the bone without extracting. What would you say to the 20% of general dentists who, in my opinion, are extremists, who say there's never a case for 4 bicuspid extraction, and if their orthodontist does it, they stop referring to them? What would you say to those guys?
I would say there's definitely some cases. Obviously, we have, the way we look at it is airways first. If we can develop the arch, we'll develop it. Then we'll look at it as the function and the aesthetics in terms of like, what does your profile look like? So if we extract teeth, are we making that profile worse or better? And then there's this crowded case that has tons of crowding in the lower. And by taking 4 bicuspids out, you have no way of making it without it because there's no bone to put the teeth in. So there are some cases, there are not very many, that you have to extract teeth. And you have to understand, as long as it doesn't compromise airways, which comes first, and doesn't compromise the profile and the facial aesthetics, you go ahead and do that for the health reasons. And I think it's just a simple explanations for those airway friendly. And I take out very, very little teeth. I mean, and I've always been a non-extraction, kind of slow expansion type of orthodontist. And because I'm passionate about sleep apnea, especially for kids, I'm trying to develop arches early. That's why I want to see kids early. I want to get rid of their habits early. I want to be able to get their jaws to grow normally and develop the healthy habits. If I could see kids earlier, then I can address it. But in some adults who've never been seen with a severe crowding, I have to do it.
Okay, well, that's another big controversy. I'm so glad you walked into that glass door for me, so I don't even have to set it up. I've seen periodontists, pediatric dentists do phase 1 treatment and sitting at a table, and the orthodontist is upset because he's saying, okay, you didn't do anything to help me, but you used up the $1,500 insurance benefit. And I've seen them go back and forth, several times in 30 years. So I've seen it. Talk about, why do you think there could be some misunderstandings between early intervention with pediatric dentists and orthodontists, which the segue, well, first answer that, because I think 1 + 1 + 1 = 3, when Clear Choice implantologist, periodontists, teamed up with the prosthodontist to restore it with the lab tech, we saw a Clear Choice, And my gosh, it's huge. I mean, they placed 18,000 arches last year at $25,000 an arch. That company's been sold 5 times. And now I'm starting to see pediatric dentist plus orthodontist equals 3. If you see a pediatric dentist open and an orthodontist open versus across the street a pediatric dentist and an orthodontist, because if you take 100 kids into the pediatric dentist, they're all going to ask, hey, do you think little Billy's going to need braces when he grows up? And you know, Jan, you're going to get that question. So instead of saying, oh, well, here's another form, you got to go down the street, make another appointment, see another doctor, fill out another chart. Oh, we're all right here. So succinctly, why do pediatric dentists and orthodontists disagree about early treatment? And do you think the solution is to put them all under one roof in retail, convenience, the butcher, the baker, the candlestick maker, all in retail?
Yeah, I mean, I think that it's obviously a good choice to the orthodontic pediatric dentists when they work in tandem and they have the same philosophy. It's a great match, and I think it shouldn't be any conflict. If there's a pediatric dentist that will ask me, "Hey, help me out with my early treatment," and later on you could finish the cases, I would absolutely be supportive of that. I will teach him as much as I can on expansion, on habits, on class 2 correction, on early, expansion. And I think that there's definitely a merit to it. And I absolutely think the pediatric dentist can handle it. They just need kind of a partner. They need an orthodontist to partner with and feel like, that they could be supportive of what they do. But those combined practices, whether you're in the same location or you're 2 blocks down the street, you should be able to come up with the same answer. And I think pediatric dentists are now getting into sleep apnea, at least in our area in San Francisco. And now we're finally finding this connection that we understand why we're doing things. So I think that this 1 + 1 = 3 absolutely works. It doesn't have to work in the same location. And I feel like, again, plugging in AI will be able to help with diagnostics and screening to tell, okay, this patient needs has problem with the spacing, or, it will automatically detect this.
Here's another controversy. Some say a rapid palatal expander only works before a certain age, and after a certain age, it doesn't work. And when you expand the palate after that age, all you're doing is tipping the teeth out. You're not making the maxilla larger. Other people dispute that. Where do you sit on that?
I feel like, I agree the early expansion with the palatal expander is much better, because when the permanent teeth come in, they come in and bring the bone with it. So, but I do know that now we're expanding in adults with a mini screw. So we put an expander, we put some mini screws, and we can expand the suture in the adults. So I feel like, this expansion, even though we think the suture is closed, it might be ossified, but not closed completely. And we're finding out that some of the cases that we did Lafort surgery, for expansion or rapid expansion with SARPI, right now we can expand with an expander and putting some mini screws in the palate, and we're able to expand the stuff.
With everything, there are extremist deals, and I don't mean extremism as good or bad or whatever, but some people are kind of obsessive compulsive disorder about occlusion. I mean, they're fanatics. And it seems like on Dental Town, if you're just really into occlusion, you don't have a lot of good things to say about orthodontists, because they say, well, they blow away the curve of Spee, the curve of Wilson, they flatten everything. What would you say to people who are naturalists or occlusion? They worship the curve of Spee, the curve of Wilson, and they just don't like blowing that out. What would you say to them? Is it are you worried about that, or do you think it's not a big deal?
I don't think it's a big deal. I think my number one kind of teacher is Larry Andrews, who did the 6 Keys of Occlusion. I think he evaluated many models over the lifetime, and he's done a lot of investigation of what the perfect teeth and the perfect smiles and how they last, and checked them over the years. So I think the 6 Keys of Occlusion is a fundamental study, and that should bring people together. And Larry Andrews, geniusly wrote the book and created the straight wire appliance. And so I think that there's definitely, if they work together, they can come up with a consensus of what occlusion should look like. But that's purely my opinion.
My gosh, that was a long time ago. When did he write that, in the 70s?
Yeah, I had a privilege to still study under him and go to his office and take his courses. It was phenomenal. He's definitely an amazing person and a genius in orthodontics.
Is he still teaching?
I think his son took over. I don't think Larry is teaching anymore.
So Will's the big teacher now?
Yeah, that's right. Will took it over.
Huh. That's yeah, interesting. So what else are you most passionate about? I mean, I feel like I'm not even smart enough to ask you questions because you have so many degrees and companies, and you went to Harvard and I went to Kansas. And so what do you what else are you most passionate about in orthodontics?
Well, I think just the concept of occlusion, creating smiles, facial aesthetics, being able to provide a very efficient treatment to patients, given what they want. I love orthodontics now after 20 plus years, more than when I came out of residency. I feel like I understand more and I feel like I can help more people. So, like I said, airways, sleep apnea, TMJ treatment, I understand so much more, and we can do so much for those patients that some of them are miserable, and giving people beautiful smiles and understanding how important it is. I mean, I'm passionate about all those things.
And when we just talk about AI in dentistry, not just ortho, but AI in dentistry, what do you think dentists misunderstand the most? What do you think they believe about AI where it's not right? And you got
Well,
to.
I think they don't have a full picture of the function. I think they look at the teeth, and not all of them, but and they don't understand how does it relate to airways, or what is my TMJ relationship, or how does occlusion affect the muscular apparatus of the face. And I think AI is going to be able to put it all together. And some dentists, if they're good at certain things, they forget about other things because that's what they're good at. It's just a natural tendency of a person. I think that AI will give them a broader scope of things. We'll be able to look at the person in 3D and evaluate the digital patient.
And another controversy is there are some clear aligner people that come, especially the Invisalign crowd, that say they can do every single case with Invisalign. Do you think that's an exaggeration, or do you think
Yes.
that's spot on?
Sorry to interrupt you. I think it's exaggeration. I think there's some cases that absolutely need braces. We use Sure Smile system that robot bends the wire and kind of adjusts things. Pre-surgical cases, there's some cases that need intrusion of the molars and movements that are in 3 dimensions that Invisalign doesn't have as much control over. So I do believe that Invisalign can treat a lot of cases, but I don't believe that I believe there's a definite place for braces and an ability to get a better result.
So on Dental Town and Ortho Town, we're always hearing dentists and orthodontists saying things that they have a patient come in and they're a Smiles Direct Club patient and they want the orthodontist to take over the case or make them retainers or things like that. Yeah, that's tricky. I mean, they went to Smiles Direct Club to avoid seeing you and paying you money. And now when they're done, and again, I still think leveling, aligning, and straightened teeth, my God, that's the easy part of orthodontics compared to retention and retaining. I mean, how do you finish a orthodontic case on an 18-year-old and expect them to still be straight when she's 68? I mean, it's not going to happen. But what are your thoughts when a Smiles Direct Club patient comes in and says, Will you take over? Will you finish? Will you make me a retainer? What do you do?
I mean, I just do it, and I think whether it's Smile Direct or another orthodontist or another dentist who's doing Invisalign or somebody who hasn't finished the treatment, and I basically take it over and I do it. I mean, it's just part of what we're supposed to do. Some people are happy with the results of the minor changes, and some people are not. And I think our duty is to help them no matter what they come in with.
Nice, man. That's nice. So, what other technologies, I mean, do you use in your orthodontic office that you think is new and exciting? I mean, do you use Weave or any other technologies?
No, I mean, we don't use Weave, but we use voice over IP, and we kind of try to create customer service experience. I think that with the AI and the 3D scans and intraoral scans on this digital patient, we're starting to use digital smile design and collaborate with dentists on like where we see the case at the end. I think that's pretty much it right now. There's a lot of sleep apnea screening and working with the ENTs and the pediatricians and getting back into the medical community. That pretty much occupies all of my time.
A very difficult subject to talk about. So I figure since we've gone over an hour now we're just on overtime. So if I ask you a question, you tell me to shut up and hang up, we're good. Is the young kid wants to learn Invisalign. It seems like when they come out of school, they go one of two ways. They're either blood and guts, and they like to pull teeth, do root canals, place implants, and that's what I recommend because that's what 8.5% of emergency room visits are odontogenic in origin, and public health dentistry is one of the 12 specialties, and it just fries me. It just makes me upset when someone goes into a dental office in severe pain and they can't fix it. They're like, well, I can't pull a tooth. I can't do a root canal. And I'm like, well, then give your license to someone who can. So I recommend blood and guts, extractions, root canals, maybe learn how to place an implant later. A lot of the crowd says, I hate extractions. I don't like doing root canals. I don't like blood and guts. And they want to do bleaching, bonding, veneers, and Invisalign. But, they sometimes they get nervous because they think the orthodontist across the street is going to find out that they're doing Invisalign, and they're not going to love them anymore. They're not going to be their friend, and they're not going to get cookies at Christmas. What are you thinking when you see that young dentist across the street start doing Invisalign?
Well, I think that the key part is for them, they need to find a mentor. I don't have any problems for young dentists to do Invisalign because, they can do pre-prosthetic cases, they can do other things. So I'm very supportive of dentists doing things, and learning and advancing. And I think some of my best referrals are the ones who are doing Invisalign, but they refer complicated cases. So I have no issues personally, professionally, and otherwise when they do Invisalign. I think working with a mentor, whoever it might be, working through the cases, getting some help, not getting in trouble and taking more than they chew on is the key factors. Like start simple, get a mentor, work on the cases together, understand how the mentor is thinking who've done a lot of those cases. And that would provide a very good collaborative environment.
And if that person got into Invisalign, and some of them are also into high tech, I mean, so many of these dentists, especially the younger ones, are just all high tech, and you think they were born in Silicon Valley, so they want to make their own trays. They want to get an Emerald scanner from Plan Mecca or Formlabs 3D printer or the iRock DDS or whatever. What do you think? Are you there? Are you oral scanning and printing trays chairside? Where are you at on this?
Yeah, I have a 3D printer. I have a scanner. I do some printing, very simple cases. I still feel whatever the outcome, the software part of it is very important. And I feel like your own printing is definitely has a merit, but I don't think it saves you time or money or creates more precise situation. So, it's how you get the final product really doesn't matter, whether you get it from Invisalign or you get it from ClearCorrect or you print the 3D trays in your office. As long as you know what you're doing and you know which plastic you're using and how to move teeth, it's all okay. I don't have any problems with all three of them.
Wow, that's a great answer. Was there anything else that you were that you're passionate about that you want to talk about that you thought I'd bring up, or
No, I think I really appreciate the opportunity, Howard. I think your podcasts are great. I think that you teach a lot of dentists. I appreciate the fact that you're really doing this work, and I've learned a lot from your previous podcasts and listening, and I appreciate having me on the segment.
Ah, man, you're too kind. I appreciate you, and I think what you're doing is well, the last question is this. Endodontist, I mean, my gosh, the biggest controversy they have is maybe sawn endo, and sawn endo, to me, it's not. To me, I'm a little confused because the hardest part about an endo is finding the MB2, finding the four canals, and getting me all worked up to a size 20, and the sawn endo doesn't even start taking over till that point. And so, in pediatric dentistry, their civil war is over silver diamine flora. But man, orthodontics. Oh my God, you're under publicly traded Smiles Direct Club. You guys are being attacked. From so many different angles. So I was wondering if there's some kid in dental kindergarten school and she's thinking, well, when I grow up, I want to be an orthodontist. Would you, looking at, because you're in Silicon Valley, you see all the technology flying around you. Would you say, hey, there's 12 specialties you might want to look at, endo or pediatric dentistry?
I love orthodontics. I would encourage my kids to go if they ask me. I'm not going to push them, but I really like it. I think it's there's a lot of applications. Like I said, there's whole sleep apnea thing. There's TMJ. There's bite. There's always a room for good orthodontists. And I don't think any direct-to-consumer or publicly traded company is going to take it away. I think that we're here to stay, and we're here to advance the dentistry and help a lot of people.
So Nashville's not scaring you?
Not at all.
All right. Well, that's a good thing to close on. Thank you so much. I know you did this at the end of your day. You saw patients all day. And then at the end of your day, instead of going home to your three kids, you stay at work and talk to me and my homies, and I really appreciate it. Thank you so much for doing this at the end of a very long day. It was just an honor to podcast you.
Same here. Thank you, Howard. I appreciate it.